Clinical Practice Guidelines for Neck-Associated Disorders. Updated Canadian Guideline Recommendations for Chiropractors. Guidelines are often viewed with suspicion. They can be cumbersome to navigate, often have no solid recommendations for certain approaches due to lack of strong literature evidence, and if they do not recommend or support a specific approach, they are often viewed as potential leverage for payers to deny reimbursement. Yet guidelines that are designed to reflect the current literature and focused on non-biased, high-quality scientific publications are needed to demonstrate at least an attempt to synthesize what is known. The concern is that payers may view these as rules and not guidelines. However, good guidelines make the qualifying statement, at least for the menu of treatment choices, that selection should be based on patient and practitioner preference. So why a new guideline? The Ontario Protocol for Traffic Injury Management, or OPTIMA Collaboration, recently updated the systematic reviews from the Bone and Joint Task Force on neck pain and its associated disorders, with the intention of replacing and combining two chiropractic guidelines for neck-associated disorders and whiplash-associated disorders into a single guideline. The original guidelines were from the Canadian Chiropractic Association and the Canadian Federation of Chiropractic Regulatory and Educational Accrediting Boards. The title is The Treatment of Neck Pain-Associated Disorders and Whiplash-Associated Disorders, a Clinical Practice Guideline. This was published in the Journal of Manipulative and Physiological Therapeutics in 2016. Note a very significant change in authorship from even 10 years ago. 7 of the primary authors of this study are combination DCs and PhDs. In the world of research, this speaks volumes with regard to the level of sophistication that chiropractic research has achieved. So let's review some general statistics prior to reviewing this extensive review and recommendations. So although the annual incidence of neck pain is reported as a range from 10.4% to 21.3%, what's not obvious is that the Bone and Joint Decade Task Force reported that 50 to 75% of individuals with neck pain also report pain 1 to 5 years later. And specifically for whiplash-related injuries, the global yearly incidence rate of emergency department visits as a result of acute whiplash injuries is between 235 and 300 per 100,000. In 2010, there were 3.9 million non-fatal traffic injuries in the United States, with total costs in 2010 of $242 billion, including $23.4 billion in medical costs and $77.4 billion in lost work productivity. More than 85% of patients experience neck pain after a motor vehicle accident. Short-term recovery is reported as 29 to 40%. The median time to a report of recovery is estimated at 101 days, but 23% are still not recovered after 1 year. The classifications used by most researchers, and also used as categories for recommendations in these guidelines, includes neck-associated disorders and whiplash-associated disorders. The NAD grading was developed by the 2000 to 2010 Bone and Joint Decade Task Force on Neck Pain and its Associated Disorders, while the whiplash-associated disorders grading system was developed by the Quebec Task Force, commissioned by a public insurer in Canada. Here we see the NAD grading system. There are 4 grades in each classification system. Although each was developed by different groups, they overlap with regard to inclusion and exclusion definitions. For example, Grade 3 represents neck pain with associated neurologic deficits, and Grade 4 patient presentations are in need of referral due to signs and symptoms of major structural damage, such as fracture or dislocation. Grade 1 is a bit different for NAD and WAD, with the WAD indicators of neck pain with no objective findings, and NAD being signs and symptoms not indicating structural damage, and no or minor interference with activities of daily living. And Grade 2 for WAD designated as neck pain with objective findings but no neurological findings, with the NAD version being no signs or symptoms of major structural damage, but interference with activities of daily living. This was a very structured, extensive, evidence-based approach to review and recommendations. Let's review some of the process. There were 6 topic areas: exercise, multimodal care, education, work disability, manual therapy, and passive modalities, which were reviewed in relationship to the conservative management of neck-associated disorders and whiplash-associated disorders. There was a 2-step process, including establishing a threshold for clinically meaningful changes and then making recommendations on which were relevant studies. In addition to the publication team, there was an external 10-member committee of stakeholders, end users, and researchers from Canada, the U.S., and Lebanon. They formulated and addressed a total of 29 key questions and then discussed the evidence and recommendations for these, if any could be made. The review is a great example of how few studies actually qualify in a very strict process with exclusion based on quality and bias. The initial yield was 7,784 articles. Through a process of finding duplicates and then eliminating those not meeting the criteria, 7,732 were eliminated. This left only 52 studies, with 12 related to multimodal care, 3 related to structured patient education, 8 related to exercise, 4 related to manual therapy, 2 to soft tissue, and 6 to passive modalities. And then, only 4 articles out of the 52 RCTs were judged scientifically admissible for inclusion in their synthesis. These are categorized by 3 systematic reviews and then 4 included studies within these reviews. For multimodal care, it is the Sutton et al. Review of 2014. Included studies are Monteconi et al. And Myers et al. For workplace interventions, it was the Varatharajan et al. 2004 review, with the included study by Graham et al. And for manual therapies, it was the Wong et al. 2015 review, with the included study by Dunning et al. There are a number of unique features of this recent set of Canadian guidelines. They use clinical questions as the focus for examining evidence and making recommendations, and not all have enough evidence for the team to make recommendations. They synthesized this information into a practical set of algorithms, and they produced public education pieces that fit onto a 1-page summary. So unique is that they also include guideline statements of what is not recommended. Let's start with those. For neck-associated disorders, grades 1 and 2, from 0 to 3 months, they do not recommend structured patient education alone, strain counter-strain therapy, relaxation massage, a cervical collar, moist heat, electrical muscular stimulation, or electroacupuncture. And for neck-associated disorders grade 1 and 2, at 4 to 6 months, note that structured advice and the cervical collar were removed, meaning they might be recommended. But not recommended are clinic-based supervised high-dose strengthening exercises alone, TENS, pulsed shortwave diathermy, or a standalone course of relaxation training, or botulism toxin injections. And for neck-associated disorders grade 3, these are the ones with neurologic deficits, from 0 to 3 months, what are not recommended are structured patient education alone, a cervical collar, low-level laser therapy, or traction. And now the recommendations. For neck-associated disorders 1 and 2, 0 to 3 months, they recommend multimodal care, manipulation or mobilization, or range of motion home exercises. For neck-associated disorders 1 and 2 that are persistent greater than 3 months, they recommend multimodal care or advice alone, multimodal care or stress management, high-dose massage, home exercise, supervised group exercise, yoga or strengthening exercises, supervised exercise or advice alone, and high-intensity strength training or advice alone for workers with persistent neck and shoulder pain. And recommendations for neck-associated disorders 3, these are the ones with neurologic deficits, for less than 3 months, supervise graded strengthening exercises, and for persistent, those lasting longer than 3 months, multimodal care or advice alone, or mixed supervised and unsupervised high-intensity strength training or advice alone for workers with persistent neck and shoulder pain. Recommendations for whiplash-associated disorders were for whiplash-associated disorders 1 to 2, for those 0 to 3 months, multimodal care, for persistent presentations greater than 3 months, supervised exercise or advice alone, and for whiplash-associated disorders 3, again those with neurologic deficits, up to 3 months, multimodal care is recommended. However, for persistent greater than 3 months, no recommendations were made. The OPTIMA team should be congratulated for taking on such an extensive revision. The amount of time spent in review, discussion, grading, and writing is noteworthy. Ultimately, their goal was to synthesize the information into a single document with helpful appendices that summarize information, and by using clinical questions assist the clinician to determine what's the best recommendation for a given patient. Unfortunately, we're still at a point in time where there are many options with limited evidence, making the task of making recommendations difficult. No one is satisfied, but as a measure of progress, much has improved both with process and with the researchers doing the work. Hopefully, more definitive comments and recommendations will evolve as the literature improves with more high-quality studies to include.